yesterday and today because there was there were many webinars going on at the same time around the 7th, 8th of April because the week on One Health and international events, etc. So it was so overloaded. There was no people were not available, basically, not even the panelists or public. So we therefore decided to move the second one to later in the month to have more flexibility and more availability on both panelists and public. But they are linked anyway. Huh? And so this second webinar is meant to be more scientific somehow, okay, with longer presentation and more description of results, etc. Less political, more scientific, but they are both on the same philosophy, which is that to summarize it is that something that is not written, that is not published, never existed. If we want this webinar to exist, to leave a trace and to say something and to people and people to get what we want to say, we have to publish it. So the idea is to make 4 papers out of this webinar. The first paper will be some sort of white paper, corresponding to the webinar on 7/8 on policies and governance, etc. What will be the future, what we must do, etc. With everybody as co-author, but it will be mostly on the first webinar and the plenary session of that webinar. And plus 3 papers which will be specialized paper. One on infectious diseases and vector-borne diseases, one on pollution, and one on AMR. And each time we'll ask people involved in each section to lead the writing of this kind of review or rather concept paper on each on each section. So my initial idea, but this is open to discussion, we can change. My initial idea was to submit the one on infectious disease to IDOP, Infectious Disease of Poverty, which is a pretty good journal with a good impact factor. Then the one on pollution maybe to environmental research or another good journal on the topic. And we need to find a good journal for AMR. I thought about maybe Journal of Infection, but we will discuss that together. So after these sessions, I will contact each group separately to launch the process. I will myself be more involved in the first paper, but we will set up 3 other groups to work on the writing of the specialized paper. Okay, that's all I wanted to say as introduction. So thank you, all of you, for attending this morning, or this afternoon for you, but morning for me. This session, so we're going to start with the session on pollution. And the first speaker in this session will be Dr. Annisa Utami Rauf from Universitas Gadjah Mada in Jakarta, in Indonesia. And she's going to talk about microplastics, especially in Indonesia, but maybe not only. So with no other delay, please, Annisa, I give you the microphone, the space, the floor is all you. Thank you.
Merci, Prof. Roger. Bonjour and good afternoon. Greetings from Indonesia. I'll share my screens from here. Yeah, I hope it's could be seen. Okay. Okay, thank you very much, Roger. Hello, everyone. Good afternoon. My name is Annisa Utami Rauf. I'm from Universitas Gadjah Mada, Indonesia, and today is an honor for me to present about one of the interesting topics, and also this one of my research interests. It's about the microplastics in the One Health framework. So in the a few minutes later, we'll talk about how microplastics as an emergence pollutants will influence the health of global populations, and how we as a researcher will take an actions, and also how the recent updates of these pollutants going right now. And yeah, I'll say good morning to all of the professor and our college and all the participants. And yeah, I'll start with, yeah, allow me to give a brief introductions about myself. So currently I serving as a assistant professor and researcher in the Faculty of Medicine, Public Health and Nursing in Universitas Gadjah Mada with a focus on environmental toxicology, pollution and interconnection of health of human, animals and ecosystems. So this is a few of our selected works. So currently we in June, maybe next June, we will publish our book. Me and Prof. Wibawa also in this panel we launched the One Health concept in Asian context. So maybe everyone that have the same interest, you may check our book, and some of us studies regarding the pollutants, especially for the microplastics and some toxicological pollutants. And also I included some my past and ongoing projects. So maybe everyone that has some interest with me, we will have a good discussion later. So if we talk about microplastics history, how microplastics become challenging not only in the environment but also in all aspects in our life. So we'll start with the history, how the plastics start to have or have been used of the human in Earth. So to understand, we often think that microplastic is a modern discovery. Their presence is actually rooted in the 20th century. And in this timeline, it illustrates the transitions from the wonder materials to the global pollutants. And yeah, the story begins in 1950, where following the surge in mass plastics productions post after the World War II, and it wasn't long before these materials began to break down and enter the environment. And in 1971, the first scientific observations of plastic particles were recorded in marine environment, especially within the North Atlantic Sargasso Sea. And this was the first red flag that plastic was not simply disappear, but floating on the river and fragmenting into persistence or into the smaller pieces. And then in the early millennia, significant milestones occur in 2004, where the term microplastic was officially coined by Professor Richard Thompson. And this provides a unified name for the particle smaller than 5 millimeter and sparked a global surge in research. And in 2010, our perspective shift as we began detecting microplastic in the most intimate places, including the human lung, blood, and even the placenta. And they have since become a marker and become the one of the challenges in environmental media. And in the 70 years since the inventions of the plastic, microplastic has moved from the industrial innovation to pervasive or toxic biological presence. And this historical context is vital as we apply One Health framework to manage their future impact. And recent years, a lot of study have identified microplastics in all the media. And in human itself, like I mentioned, it's also detected in the lungs, in the blood, and in the placenta of the human. And yeah, you could see from this picture, there are two pictures here. And as I mentioned, that microplastics is accumulate. It's not only in the water, in the soil itself. Some of country have publications or projects to reduce the accumulations of microplastics. And in soil itself, we could see that on the sand, in silt, or the clay, the accumulations of microplastics is increasing over the time. So we could understand that this accumulation will be threaten the human health, and also if we connect it to the food web, the animals and the environment will be threatened by the accumulations and the increasing numbers of microplastic in any types. And yeah, the dangerous issue about microplastic is not only that occurs in the large amount of the environment, but also it's really difficult to degrade, and it's synthetic materials, and not only been around for a few years, but it's always it will be around for decades. So some research also mentioned that microplastics will degrade. It needs about 100 years of time to be disappear from the land. So it's really challenging for us, even for the West countries. And however, the textile microplastic are create every day. So it means that even though some actions already done, and there is a good result, but the challenge is the amount and the volume it's still produced every day. And we could see from this finding, we see that microplastic are now one of part of our life and found in every media, including in the air, water, food, and human body. And continuous exposure is unavoidable. So yeah. And why the microplastic is a big concern, and not only for a country, but also we as a global citizen, because the first one is there is a difference in sampling, detections, and characterization methods across the studies. Some countries or some researchers using different methods. So the implication would be the different result and the different understanding how we need to characterize microplastic itself. And this lack of standardization will implicate the implications will be the inconsistent and incomparable data. So there is no, at least in here in Indonesia, the methods is different from one lab to another lab. So it means that if we want to detect or if we want to see the accumulations of microplastic in some media, they sometimes use a different method. So it's really hard to make it like one rigid method. And the second one, there is disconnections between the model that sometimes we found in the recent papers with the real-world integration limits that using for the aggregate exposure pathway. So for example, if in environment we detect the microplastics, sometimes we need a longer time to see how these microplastics in the environment will influence the health of population, because it's emergence and also still ongoing research. So we don't know that few ppm, for example, 2 ppm of microplastics will have like the same symptoms for people in the same age or a different age or different jobs. So there is a challenge in the method and then the disconnections of the model itself. And the last is the fragmented collaborations, because some of sectors seeing microplastic is environmental issues, but now we are facing, and some data already found the microplastic in human body. It means that later we will have like we will have like negative effect regarding these conditions. And due to the status of the microplastics that still emergence, more data and more collaboration is needed for these conditions. Yeah, for One Health and microplastics, we can see that the connections itself is can be found in the food waves topics, because animal health, human health, and ecosystem condition is totally connected. And if we could see from this picture, we can see that the exposure of any kind of actions or any kinds of pollutants, including microplastic, will influence the health of animal, human, and the conditions of the environment around us. And yeah, the microplastic itself is, some article saying that microplastic is a Trojan horse. Why? Because if we found the microplastics in some conditions where is the area is having pollutions, the pollutant itself, for example, the heavy metals, will affect 45 until 50% effect to the health of the populations. But if we can detect pollutants and microplastics, because recently microplastic able to absorb some kind of pollutants, the effect will be worse, and it could be 2 times effect rather than the pollutants itself. And the bioaccumulation rate will be increased 65% from the accumulations of common pollutants with the microplastics. So the rising volume of microplastics with the rising volume or rising concentrations of pollutants will double the effect of the health of the populations. And for the soil pollutions itself, in China, in the normal soil, if we don't detect, or we don't there is a land that there is no accumulations of microplastic, the soil will be produce a good plants, for example, the corn. But if there is accumulations at any concentrations of microplastics, there will be problems of the growth of the plants. And the growth will be, there's problems because of the microplastic will be block their growth process. And in the, it's previously I mentioned about the soil pollutions, and for if we look at the atmospheric conditions, we could see that if the microplastics could be scattered or distributed with the help of the wine itself, there will be the atmospheric evidence depending on the altitude, locations, and the season. Higher concentrations typically found near the ground due to the gravity and the atmospheric temperature or pressure. Temperature gradients drive vertical movement of microplastics in the air, while the temperature inversion can trap microplastics near the surface. It means that it will be limiting the dispersions and increasing the localized pollution in here. So if the microplastic or nanoplastic becomes smaller, the atmospheric conditions that influenced by the wine will be scattered this particle around, and the wider the distribution, the the wider area or the more area will be have microplastic pollutions. And then if we talk about solar radiation, it will be make the microplastic having the photooxidations reactions where the changing microplastic size, surface properties, and reactivity. It will affect the transport interactions and environmental behavior of the microplastics. And the last one, a degradation process will break microplastic into lower molecular weight particles and enabling long-range atmospheric transport. So the atmospheric conditions is also having like a high risk of the accumulations of the microplastics. And in the ocean itself, of course, because some countries rely on the healthiest biota, for example, the fish consumptions, the shell, and others, the pollutions of the microplastic is in the oceans is really high. The risk is really high. We could find that some fish or some part of microplastic already accumulate in the intestine of the fish, and the activity in the area or in the oceans also influence the quality of the fish that we consume every day. And if microplastics is accumulated in the fish, there will be some problems with the growth of the fish, starting from the oxidative damage until the mortality. And we could see that the accumulations of microplastic and also the type of the microplastic in Indian Ocean is really diverse. But in here, we could see that most abundant polymer type is PE, and then most abundant microplastic shape is in the fiber. So some countries might be different. It depends on the consumptions or the utilizations of the plastic in the area. And yeah, if we try to make connections with the One Health, because we have farm animals that we consume, and then the risk of the microplastic possibly there's for example, the household waste that contain the cover of food, and then there is no a good waste management in the area, and then some animals able to eat that waste that not separate or that not manageable good enough. So there is a risk in the livestock consumptions, for example, the goat or the chicken or the rooster, because some of them will eat the smaller plastics that will expose to their food. And in Asia itself, we try to find some data, and then in this book, written by Professor Eboneri, about the microplastic in African and Asian environment, we could see that the size and then distributions of microplastics is vary drastically across the region. For example, in Iran, there's a high concentrations of smaller particles, and in China itself reports a larger presence of particle exceeding. In Da Nang, Vietnam, the dominating fragments dominate by fragments and films. And in Chennai, India, some fibers are likely originating from the synthetic of the textile. And yeah, and if we see in this slide, I have like a book chapter that already published by Springer. There is some studies that using remote sensing and geographical spatial informations to detect microplastic around the countries in Asia. And some of the countries able to do that, but some of them is still under developing. For example, the machine learning model is significantly improved detections, the accuracy and the efficiency, because some geographical condition is really challenging to image to make a good imaging. And then the remote sensing, for example, reveals that the key pollution source, including urban waste, agriculture and industry, is also influenced by the marine activities. And then the challenge using this kind of technology is, of course, we need more funding and we need more experts that understand the technological side. So the database is still ongoing, but it's also promising to see what should we do next using this kind of technology. And yeah, there's also some innovations that using by several countries or nations. For example, me and my students try to developing a Dropbox, and we put in some side of the area in the university. So we separate cosmetics waste that from plastics or from glass, and then there is some stakeholder that they able to recycle it. And then some actions, for example, alternative materials to replace plastic itself is needed. For example, in Indonesia, there is plants, we call it eceng gondok. I forgot the Latin names, but yeah, this one is the picture. Some of the researcher using these invasive plants, as I know this one is invasive plants, and use it as a replacement to change the plastic, because it's more non-toxic rather than plastic that we use today. And yeah, for mitigation, another preventive strategies, of course, we need to change the behavior or change the components of plastic that always use every day. If we can able to, or if we can change it, or we can replace it to another more environmental friendly, yeah, we don't use the micro plastics at all, or don't use the plastic at all. And some countries already ban the plastics, but some is still ongoing how they decided the ban of the plastics in the area. Some cities in Indonesia also not permitted the use of plastics in retail place or in the supermarket. Yeah, for microplastic itself, besides the negative impact, I found that there are two promising actions, and we could use these pollutants as drug carriers and probiotic interventions. In the studies that by animals, by mice, some articles, these two articles mentioned the emerging research explored the use of microplastic in cancer therapy as a drug delivery system. These highlight their potential for targeting the bioavailability. And yeah, of course, the key benefits if the microplastic is effective as a drug carries, it will be high targeting efficiency and also reduce the systemic toxicity that we are facing today. And of course, we will have a sustained release from the use of microplastic. And the last one is probiotic interventions, because probiotics like Clostridium dalinum show promise in mitigating microplastic-induced intestinal damage, and it's also offering novel preventive and restorative strategies. And it will help the medical area to enhance the intestinal barrier's functions, reduce the inflammation and stress, and restore the healthy microbiota balance. This is not my really research interest, but for me, even though the microplastic have several making problems in terms of environmental pollutions and health, we could find also that there are some promising studies that possibly use a microplastic as a drug carriers and a probiotic intervention, and yeah, it possibly will help the health of the populations. Yeah, thank you. That's all from me. Thank you very much, everyone. I'll give it back to Prof. Roger.
Thank you very much, Annisa. As I said before, we had to merge the two sessions because we could hold only two sessions in parallel. So we merged pollution and AMR. So we need to move immediately to the second talk because by Dr. Theerasuk Kawamatawong from Bangkok, because he's also at the hospital. He has patients waiting for him, so we are a bit tight in time. But we will discuss all that after the last talk on pollution by Jean-Marc Roda. We will take a short time to discuss, ask questions, and then we will move to AMR. So please, immediately, I would like to ask Theerasuk, Dr. Theerasuk, to present his talk.
Thank you. I'm gonna share
Thank
the
you.
screen. I don't know because I clicked the screen for sharing. I don't know. Is it
You
possible
can
for
share.
this? Is that possible?
You can share. You can share.
I will, but you know, it's a problem because I don't know the system of the Zoom has some problem. Okay. Can you see the screen? Unable to start the video.
No, not yet.
The camera is being on for using other system. I don't know why. So I have to turn off some irrelevant screen. Okay. Can you see the screen? The app allow the app Zoom.
For the moment, not for the moment.
I don't know why, Roger, because I try to fix this problem. It's now streaming, but I have no any problem with the Zoom before, but now I cannot share the screen. I don't know why.
You cannot share your screen?
Just a moment. The video is doesn't on. unable to start the video this time. Please resolve the error and restart the video. Oh my God, I don't know. I don't know how can I.
You send me a presentation, but it's a PDF. It's not a PowerPoint.
No. I want to use my computer for my convenience. I don't know the computer about the system error of the Zoom.
It's on Zoom, huh? You just.
I try to share my screen because it's a problem. I don't know. They said it's. I'm gonna take a photo for you because it's a big problem because the screen cannot be shared. I don't know. It's problem about my computer or your system or some problem about it. I have no idea about that.
Otherwise,
I do apologize.
Dr. Amin, do you have the PDF of the presentation we sent?
Roger, I do apologize because I want to use my own computer, but I have a problem. Even the video doesn't show my face, it's blocked by someone.
Dr. Amin. No. Bon. So.
That's horrible. It's now. Otherwise, I have to close and I can send you the photo because the camera is. Oh my God. Oh, how can we fix that one? We can even wait for the whole day, but we cannot, operate this one. Turn off. Shoot.
Bon.
They say that allow the app Zoom to you to see your screen. I select the window or the screen for link. Allow.
Yes. Okay, it's coming.
I hate the system like
okay,
this.
we saw your system. We saw your screen, yes. Okay, it's coming up. Okay, it's on. It works. Please go ahead.
Let me operate by myself, please. I cannot. Oh my God.
It's working. Huh?
It's working, but I cannot play the slide.
You cannot?
I
we
cannot
see your slides, huh?
Even I cannot control my slide. I don't know why, Oh my God. Something wrong. I'm not keen on the computer system, I don't know. Okay, done. Right. I don't know. No, let just share the screen. I share the screen for the presentation. Right. I cannot even, move my slide. I don't know why.
But we can see, so you can talk and we
I know you can see my, no, it's only, I have 70 slides, but the slide doesn't move. What is that? Roger, what is this?
Professor, we shared your presentation.
No, I want to use my computer for present my own slide. Because it's not.
So it's easy to do it, but if there are any problem, we received yesterday your presentation, and I am sharing now the presentation. Are you seeing the presentation?
No, sir. I want to use my computer to use this to control my slide. I don't.
As you like.
Oh my God.
So if not, Professor Roger, also you can share the presentation and continue.
No, okay.
It's not a PowerPoint, it's a PDF, but I can.
No, the PDF, it doesn't work. I want to use my own computer with the PowerPoint, please. Let me do that. Don't try to override.
Let me check what I got.
Okay, so I stop sharing this PowerPoint or this PDF.
I want to share my slide. Okay, don't override.
Okay. So sorry for interrupting you.
It's make everything worse and worse. Can you see the screen? No. Oh my God. We should do the rehearsal in advance, not like this. This is what I wanted. Oh my God. I don't know. I cannot do anything with this Zoom because I use the Zoom every single day.
I have your PDF, so if you want, I can share.
Oh, it's horrible.
And you tell me to
Not
move
the
to
one
the
that I expect for that.
next slide.
No, sir. It's 70 slide. I cannot finish that.
I can do it with the
I don't know.
PDF.
Oh, Jesus Christ.
Okay, let's do it that way. Theerasuk, I share the PDF, and you talk and you tell me to move to the following slide.
Oh, yes.
Okay?
Okay, please go ahead. I can give you only 15-minute talk and then go. Thank you. Please show the slide.
Okay.
We waste all
Can you
time.
see? Can you see the? Can you see it?
Okay, go to the next slide, please.
Okay. So that's the first slide, the title. So you want to go to the next?
Next, all you can press every time. You can press next.
So please start. Just tell me each time next slide or the number.
Okay.
So that is slide number 2.
Next slide, please. I have nothing to say because I paralyzed my slide because can you go to the next slide, please? It's non-convenient way to present like this, Roger. I don't know why the system is so problematic.
So you can see the PDF on screen.
Yes, please,
Okay.
Roger. Can I switch off the Zoom and come back? I think can you go to the next slide, please?
But otherwise, we move to the next speaker, and
I'm not happy with that because I cannot fix this problem. I do apologize because I normally control the slide by myself, but I don't know why. Otherwise, I am not happy with the presentation because the PDF just for backup, but the system of the Zoom that's compatible with my computer. I don't know why. Can I escape from this one because I want to control the slide by myself because it's not convenience for me.
So what do? We stop now. We move to the next speaker, and you come back later this morning or this afternoon for you.
I don't know, Roger. Can you stop that one because I cannot do anything with this slide. I really
Okay.
not happy.
So we
with
just
the PDF.
cancel the talk altogether.
Please, it's very important.
Okay, no problem. We do that.
My slide, I will resign because it's complicated because I should control my slide because it's animation.
Okay.
It's animation that is to be present in the PowerPoint, not the PDF.
Okay,
but
so we can solve.
The problem is about, I don't know why the problem is about the system of the Zoom. It's not allowing me to share my slide. I try more than 1,000.
Normally, everybody is allowed to share, but it doesn't matter. So what I suggest is we cancel this presentation, okay? And we move to the next speaker. Okay, Theerasuk? So I stop sharing. I stop sharing, and I suggest then we move to the presentation by Dr. Jean-Marc Roda on Haze.
Okay, that's possible for
Please,
me.
Jean-Marc, the floor is yours.
So, good morning to, or good afternoon to everyone.
No, it's the morning for me.
Afternoon for my part of the world. I share
Okay, it's okay.
my screen. I should launch it now, and you should see in, and I have to shift. So now you see the main screen. Is that correct?
We see.
Oh,
Okay.
You should see the main slide, which is
Yeah,
about
we see the
in
first one and the
Indonesia.
second one.
Why I'm shifting again.
Maybe better to see only the slide you are talking about, not the next one. Yeah, okay.
Well, only
Perfect.
one.
Okay, only one. Okay, perfect.
As you see, the talk is about haze in Indonesia and Malaysia and how to make smart prevention. I am not a specialist of health. I will not delve into the question of how many people die, the babies or the old person or the people with the pulmonary sicknesses or weaknesses. So I will not delve into the number, but I will discuss about the process of haze, which is a pollution in itself, and how we can do to prevent it. And in this starting slide, you have the same picture in two different times. In a time when it's a normal, on the right, normal landscape, where there is no haze, and in the time when there is the haze. So you basically just see the first building in front. The rest behind is very difficult to see. And that is absolutely horrendous because this phenomena is not local, it becomes regional. I show you on the on the other slide, the current slide, that here on the slide you have fire starting in Sumatra, in Indonesia, and the haze is going across the Malacca Strait and is making Kuala Lumpur and Singapore completely blinded. It's absolutely a geological phenomena. It's absolutely scary when you are in and when you witness it. And it can go for thousands of kilometers, really. So it goes very far. So how this is happening and why it is occurring, we're going to see. But before to go there, on the mechanism of this haze, this terrible atmospheric pollution, we do a detour by why Southeast Asia is important and why the haze is terrible. Here you have a map of the concentration of carbon in pink color and of biodiversity in green color around the world. And basically when it is purple is maximum carbon, when it is green, intense green is maximum of biodiversity, and when it's black is maximum of carbon plus maximum of biodiversity. And you see that the three major basins in the world where you have very high concentrations of both carbon and biodiversity are South America, Africa, and Southeast Asia, especially Southeast Asia islands, Indonesia, Peninsula, Borneo, Papua New Guinea, Irian Jaya, Sumatra. And this is very important because this carbon is both in the forest above the ground and is also stocked below the ground in what we call peat swamps. So peat swamps are when the vegetation above ground is very slowly decomposing in a swamp, but because there is water in a swamp, it's under anaerobic situation, and it doesn't oxidize. It creates a very organic material, the prototype of what will be one day coal, or with pressure what could become even oil. So the peat is that highly carbonic material, organic and full of carbon material, and which is usually totally dumped in water. So here on the picture you have a schematic that shows you that in brown, you have two browns, a light brown, which is the mineral soil, if you see on the transect, and a darker brown that is the peat. This peat is purely organic. It's not soil in the sense of silt or clay. It is decomposed organic material that it is extremely concentrated. And you see the dashed line in blue, it shows you that it is damp, it's full of water. You have channels that people create in order to try to drain it. But even when you have channels, the peat is so spongious, it acts like a sponge. And on the top of the peat, you have trees and forest. And because of the evapotranspiration, they're actually actively pumping the water from the pit, and actually it doesn't dry the pit when it is in normal situation. It uplifts the water table up to the surface of the pit. And the pit itself usually accumulates itself under the form of domes of pits. You don't really see it at the eyes, but when you do surveys with radar or lidar, you see that you have plenty of domes of pit. And what you see there in the wet season is what is basically the normal situation if there is no deforestation. There is one problem. Nowadays, with the demographic increase in the region and also with the poverty, people try to do agricultural practices that indeed are traditional. They have done that for not million of years, thousands of years before. And before, when there were no deforestation and no El Nino, or not like we are seeing now, the weather was still humid in the dry season, and the fires was never taking off according to those fires. But now, with more demographic pressure and more deforestation, you have less forest, and when people are doing their agricultural fire to dispose the waste of agriculture, to dispose of the branches, all the vegetation, lignocellulosic objects that are a burden for them. They are waste, and they want to discard them. And because they don't have the time, the fire is the good practice for them, which make it quick and even. So in the transition period between wet season and dry season, it doesn't burn. You have scattered fires, but it doesn't burn. But what is happening nowadays is during the dry season, because of extensive deforestation, the water table is a bit lower. And some years, when you have full power of El Nino, the drought even make the water table even lower. And then what is happening? Those traditional agricultural fires that before in the past time had no impact on the landscape, nowadays they have an impact, and they start to ignite the pit under the ground. So when the pit is burning under the ground, you don't see flames, you see the phenomenon of haze. It creates enormous quantity of haze that is getting out of the landscape. And this is what you saw in the slides before. So that is the mechanism. And these are the pictures for you to visually see the landscape. So this kind of branches or bushes and everything are what the farmers there want to dispose of to do their agriculture. It is a zone where people use traditional slash and burn agriculture. They don't know how to do anything else. It is their tradition. It's very difficult to make them change of activity. And whether they plant EVA trees like you see in the lower right, or whether they plant rice, dry rice that is adapt to this kind of fires, they always use the fire to dispose what you can see as a waste of the agriculture or a waste of the forestry traditional practices. So you see them putting the fires. And when the water is just there, as you see on the left, right, it creates a bit of smoke and a bit of haze, but it is not cataclysmic because the water table is very close to the surface, so the fire cannot propagate. The fire really propagates when the water table is lower. So two factors are making that water table lower. One natural factor, which is the El Nino, and one man-made factor, which is when people are draining, doing channels into the pit in order to make their agriculture easier. But when you make channels, the water is drained, and when the water is drained, the water table is lower. Now you have on the left a kind of a vicious circle, which is made of poverty. When the peatland is, the forest on the peatland is degraded and the peatland itself is degraded, you have biomass accumulation of those, what people see as waste. And the poor people, because they are very poor and they have no time to properly do it in a way that is sustainable, I mean, they have time, but their time is counted because every day they have to work to feed themselves and their families. So the poorer they are, the more inclined they will be to put more fires. And the more fires, the more it is degrading the peatland. The more you degrade, the more you have those biomass accumulation. So it's a circle. And the idea of the presentation today is to show you that there is a way to prevent it. So you see that I put a word there that is called fire signature. If we understand what are the different fire signatures, we can understand what are the different practices, what are the different fires, and we can guess or work on how we could collect the biomass instead of burning it, and then you will not have fires on the field. And if you want to collect fires, then you need to valorize it to pay the time of the people to do it. Otherwise, they will never do it. So if you want to have incitation, but if you can break that vicious circle and make it a beneficial circle, then biomass valorization is a way to diminish the poverty, to have less fires, and then to restore the peatland, and then that becomes profitable for the health, profitable for the environment. We will see that there is a lot of CO2 emissions behind that, and profitable for the people themselves. So prevention starts with spatial diagnosis, not generic bans. Generic bans do not work because you cannot ban people who are in a survival mode in very remote areas where the density of population is very low. It's very wild places. So the people there are quasi abandoned by the state, and there is no roads, there is nothing. So banning them of doing things doesn't work because you have no way to put a policeman behind every farmer. So what is the way to go in is to use tools that we have nowadays to try to discover if we can distinguish the fires according to the land use, according to the people themselves, according to the communities, according to many factors that help us to go beyond in the understanding. And once we understand the cycle and the circle, we can break the vicious circle and we can propose prevention systems. So practically, how does it work? Smart prevention starts with mapping the biomass, mapping the fires, testing feasibility of solutions, and proposing actions where it works. So basically, the social mapping is not corresponding to the biomass accumulation, and you need to know where it is overlapping, what is not, how it is understanding. You need to understand deeply the anthropological and social vectors of what creates the fires, but also what creates the accumulation of biomass. So you need to superpose those maps where you have the fire. You need to identify the landscapes that were the most prone of fires, and you need to propose social solutions and economic solutions. So on the side, you see pictures where you have factories in the region where we are discussing, which is in Indonesia. Because our project gave a lot of ideas and people start to work on it. So you have factories that are using biomass to make different products, panels, pellets for electricity generation, biofuel for running engines, biorefinery to make biomolecules. And you see that different biomass can be collected in different way. You have traditional way of collecting the biomass out of cereals like rice. You have pellets, different ways to do pellets. You have different ways to collect and to process this biomass. This exists. We just need to put it together and to find the good biomass valorization and to put it in connection with the good need for fire prevention. So here, what you have here is showing you the map of the zone where we have done the pilot study, where we use a lot of data on different kind of remote sensing data, different kind of existing governmental and administrative data, also doing modeling and playing with the geospatial modeling, and the reality on the zone where it is. And on the map where you see there, you see that three kind of colors. Every dot of color is a fire that happened in the region over 16 years. We have done the survey over 16 years. And when it is red, our analysis finally tell you that for many reasons, physical, agronomical, hydrological, and sociological as well, we have a very high probability that the fire that you see in red is a fire created into an industrial activity context. When you see it is a yellow point, you are extremely certain that this fires was created by villagers in a traditional activity context, traditional agriculture. And when it's orange, we cannot distinguish which one. We don't know. We are not. We don't know for sure. But the result of this is here. The strong result is that 31 to 42% of the fires that you see there are definitely caused by traditional farming practices, where the people are clearing biomass. And if you look at the possibilities where there is transportation, where the transportation is feasible, where you could realistically make economic profit out of biomass valorization, we can compute that there is between 10 to 42% of the fires that could be prevented. So this is still at planning and modeling situation. We have cases where it started. Some factories have already started to work on, but it's not applied yet to the whole territory. So it is just in the infancy of the action. Now, we were speaking of health and preventing the fires for the health, but we have to realize that beyond the health, there is a major climate issue and value. The peatlands that we are speaking about, they are emitting, when they are the peatland fires, they are emitting 840 tons of CO2 per hectare and per year. So you have to realize that if you prevent 1 hectare of fire, you're also saving about 50 to 180 tons of CO2 emission. So if you do the work as the territory level, at the world territory level, you save 3 to 5 million tons per year of CO2. So we're speaking of geological numbers. Again, I didn't convert that into health figures because I am not a specialist on how the Haze act on the mortality, but we could do the exact same calculation actually in order to see how this would benefit into health preservation. Another very important thing that we have in mind when we want to do prevention, smart prevention needs to separate where it is profitable to do and where it's not profitable and will be never profitable. So the maps that you have are the 4 maps of the same area, but according the zone where you put a profitable market. So one is a factory that makes fibers, paper. Another one is a cogeneration facility that makes electricity for the city of Palembang. Another one is making wood panels out of fiber and residues of lignocellulosic products. And the last one is making bioethanol. Some of them are already existing, some of them are projects. And when you see the white color, this is the extent of where it is profitable to go to see the farmers, to tell them, do not put the fire there. Please collect that biomass. We were going to buy it to you at the market price for the factory. We're going to transport it profitably. And still there will be enough money remaining for you as a profit to be worthy of your time. The time that you will spend to collect it and not to burn the activity will be paid enough for you to be really incentive. So we did surveys on the field, having discussion with the farmers, what is the price they would like, they would stop to put the fire and so on, compare that to the market price and so on. So what you have the results are the maps in white where the market can be the prevention. So that is very interesting because today, or at the beginning of the project, there is no market, nothing. So the state is in the situation that the government needs to find its own sources to try to prevent the fire. And here we are discussing of just a little district of Indonesia, while the haze is almost everywhere in Sumatra. So there is not enough firefighters or policemen for prevention for nothing. The government has not enough money. But if you say that a significant part of it can be supported by the market itself, you don't need to pay for it. The taxpayer doesn't need to pay for it. Then it's a very efficient way to start the action. And then you have in red where it will be, according to each scenario, forever impossible to valorize the market. It is too far. The transportation will make it not profitable for the farmer. The farmers will never change their practice. In green, what you have is the uncertainty margin of where is the exact limit. So when you know where the market cannot act, but you realize that it is not the whole territory, that allow you as a policymaker to realize, what I could do there, I could focus my limited taxpayer resources on that red zone, which is the critical, while I monitor the fact that the market is saving the other part of the activity. So that is making smart prevention by being able to have differentiated action where it is profitable to the market to prevent the fires, where it is not profitable, and then when it is not profitable, you need public money to do the activity. So in the white, zero money by the government. In the red, the government should invest into 4 to $100 per ton of CO2 not emitted. So it's not a small affair. So the whole thing, you can resume it into this kind of logical framework where you have in red the vicious circles, biomass fires, degraded land, it's loops, and all of this is reinforced by climate change. So it's probably acting on climate change, I don't know how, but what is sure is that climate change is reinforcing it. And the objective is to shift from the vicious zone in red and to go into the positive zones where you can play on biomass valorization, which helps to preserve or to prevent the haze generation by land conservation and restoration. And probably that helps to mitigate the climate change issues. So this is another vision of more technocratical vision with this graph. So now I discuss a bit of the governance. Let's delve into the big question: where is the governance? So back to the same map, the same region where we did our pilot studies. On the left, in zones of colors, what you see is the demographic of the zone, and you have on the west a few zones which are red or orange, dark orange, where the demographics are higher, more people per square kilometer. When you go to the east, you have less than 10 people per square kilometer. It's really like a wild savanna, a very wild zone, and very big in terms of extension. And that's just a district. You have this situation all over Sumatra. But if you look on the map of the right, with the little squares, the density, I would say the darkening of the red is related to the density of the fires, the frequency of the fires. And if you look carefully at the two maps, you realize that with the naked eye, you see a tendency of more fires where there is less people. But it's not totally true. You see that there are fires also in the zones where there is more demographic density. So how to work when there is a paucity of data? So we use advanced techniques. Nowadays we would call AI to do that. At the time we were working manually with many factor analysis, and we understand that there are several factors that appearing. We realize that demography explains only 50% of the fires. More exactly, it explains 50% of the differences between the situation or the communes, the cities, or not the cities, the villages, zones where you have fires and no fires. So demography explains differences between villages, but doesn't explain. It explains a part of the fires, but it's not correlated completely. You don't have a strong correlation. It's only a partial explanation. Now, if you look at another factor, which is state or no state, by this I mean if is there effective governance some in the place or not. And then we measure that by the kilometers in every community zones of track roads made of dirt versus the kilometers of roads made of beton or concrete hard roads, which are made by investment of the state. The state paid to make the roads. So where basically you have concrete roads, it's a proxy of the state is there. Where you have no roads or dirt roads or track roads, there is no state, just people are doing their own tracks. And this explains another 25% of differences of fires between the different places. And it is a high correlation with the fires. So state or no state explain a lot. And when you put all together, you realize that you have about 75% of the fires or non-fires that is explained by the combination of demography plus effectiveness of the governance on the zone. So this is telling us that it is possible to plan an action, because we see that there is a correlation that is not small with the absence of the state. So we just need to put market tools that we have seen before, and we just need to go beyond into the governance, having stronger governance on the field to probably inverse the tendency. So what I am showing you is that is my final slide, with the good partnership, with the good planning and good governance, this situation of Haze are not at all doomed. We can probably reverse it. I thank you very much for your attention.
Thank you very much, Jean-Marc. Thanks a lot for this great presentation. So what I suggest is, since we have to merge two different sessions in one, is to make here some sort of break to discuss and ask questions on the two presentations on pollution before moving to AMR. And I want here now to say again something I said at the beginning, but before everybody was connected, is just that one objective of this webinar is to make publications out of it. So, as I said, we have two webinars, the one in April 7, 8, and this one. They are sister webinars. And so the idea is to have a white paper on the first webinar and the plenary session of this one, plus three concept, I would say, papers on each of the specialized sections. So one for infectious and vector-borne disease, one for pollution, and one for AMR. Okay, and then I will ask the panelists involved in each section to discuss and all together and do start the writing of the concept paper. So I wanted to give this information to everyone again because not everybody was here at the beginning when I said it. So is there any question, comment on both the presentation by Annisa and Jean-Marc on pollution? It's two different aspects of pollution. Although they might overlap anyway. People may be affected by both. So, no, I have one question for Annisa. Of course, microplastic is a major problem. It's personally something I think it's really a priority to address, but that's my personal feeling. What is the situation and the perspective in Indonesia, because I know there's a lot of plastic in Indonesia. Indonesia is maybe the first producer of plastic waste. What is the perspective for in the coming years for handling plastic in a way to reduce this major problem?
Yeah, thank you, Prof. Raja, for the questions. Here in Indonesia, as highest, the first one for highest producer for microplastics, recently the government trying to have like one regulations to stop microplastic from its source. So if we say its source, it means that we need to reduce the single-use plastics from all over the sectors. In educational sectors, for example, in our university, we have we try to educate the students to bring their own bottle, so they don't have to purchase or they don't have to buy food or water that has the single-use plastic. So yeah, it's a single steps, but yeah, let's see what's the results for the few years. But yeah, we are going in the good actions. And for the retail itself, in some supermarket, based on my experience, we cannot have plastics. They ask us to bring our own I don't know, the medium that they use to replace the plastic. So when I visit France 2 years ago, they definitely don't give us plastics, but in here some cities have specific regulations to ban it totally in the retail sectors. That's all. Thank you, Roger, for the questions.
Okay, thank you. Just a related question, actually, somehow related. But just it's very often difficult to change people habits, people behavior. Especially very often, plastic is considered as a mark of higher way of life because everything wrapped in plastic is supposed to be in better quality, etc., etc. So if you don't give things in plastics, people will consider it's not a good quality. It's very hard to change that. We have to, but it's very hard. Is there any objective or project to replace the plastic by something else, like starch or another material which will be biodegradable?
Yeah. Some research and also some funders open, if you have a project regarding the replacement of single-use plastics, it would be the priorities for the funders to accept the projects itself. For example, in some projects by the Ministry of Education, for not mistaken, they prioritize the reductions of microplastics in the environment. So, yeah, the changing behavior of people is really the prioritize for now on. But we see that the government and also some projects it's already think about it. Yeah, so they replace to more friendly materials, for like I mentioned before, like from the stars and also from the plants that may be able to change or having similar characteristic with the plastic that we always use in everyday life. Yeah.
Any other question to Annisa or to Jean-Marc, Roda on their respective presentation? No, but if not, just a very quick question to Jean-Marc. Basically, the same one. What is your vision, your perspective in terms of haze for the future? Not only Indonesia, Malaysia, maybe Thailand as well, because it's also a big problem in northern Thailand.
I would say
Should
that
we do?
Walid, continue. Yeah. Sorry, I did cut you. Did I cut you, Roger? You were finishing to talk. Sorry.
No, what I wanted to just to ask you what, in your opinion, what is the perspective for the coming years in terms of haze management or solution? What should we do, basically? Indonesia, but also Malaysia, and maybe also northern Thailand, because it's also a big problem in northern Thailand. What do you think is on the way? Things really feasible?
So the causes are very similar between Malaysia and Indonesia, and also in Thailand. The fundamental causes are poor farmers or traditional farmers that are doing traditional practices of cleaning their gardens or their agriculture with fire. Not only slash and burn, it's also cleaning your agriculture waste, even where you have very intense agriculture like paddy agriculture, people tend to put the fire to dispose of the remaining straw, that is still on the ground. The big difference in the mechanism in North Thailand, it's mineral soil, so you don't have the pit that is burning below. It's just the normal vegetation on the normal soil. And this you find everywhere. You will find that in India, you will find that in Myanmar. And the logical is this kind of practices is more practiced when people are poorer, when they are in survival mode. So in terms of health, it's terrible because there is a coincidence, of course, where the people are poorer, this is where they are the most fragile. And if they make the haze, this is where you will have more incidences. There is a fair side of this is they are sharing the haze with the rest of the people. And when you have cities down the wind, they will get it as well. And then all
people in Singapore, they know it.
These people they can survive in their apartment with the aircon and the filters. But the poor people who are living in dumps and in the slums or in the poor zones, they will totally take the hit. So mechanisms are different. The huge difference between the mineral soil and the peatland is that in the peatland, the quantity of haze that is emitted, the thickness of the haze is of geological nature. It is beyond what we can imagine. The plains are disrupted. You cannot land anymore on the airports and so on. It's really just mind blowing. And the fumes are going on. We are seeing on the satellite pictures. It covers 2,000 to 3,000 kilometers. So that's the the initial part. Second part is it is favored by El Nino. At least in Indonesia. In India, I don't know, but in Southeast Asia, El Nino totally favor it. So each time the El Nino is coming back, we know that the haze is coming back. So we have a kind of we don't know how to predict exactly the El Nino, but we have ideas of its recurrence. So we know that it is going to recur. That's a certainty. So El Nino means haze. Okay. Now we have seen together that there are ways to prevent. I would be very sad to share with you that the district where we tried this, all the maps that I've been showing you and the preliminary work with the local entrepreneurs, which show that it is feasible, which show that it works if we want. At that time was made with the support of the governor of the region, which unfortunately later on died, he passed away. So the next day he was not there. The politician ecosystem that were there stopped to support us. So my message there, it is extremely fragile to the political support. If political support is there, we start to do something. When political support is not there for many reasons, that way the unfortunate death of the governor, then it's a collapse. So the immense importance goes back to how the country takes that in its hands and start to plan these issues at a level. And that's not easy because we are speaking of long-term planning. You have seen the kind of planification that it demands. It demands data, crossing data, and so on. So doing that in all the provinces where usually the data is not very good, it means that your planning agency needs to see ahead for the next 5, 10, 15 years, something. You don't do that. And as a politician, if you tell him, oh, the solution will emerge gradually in the next 5, 10, 15 years, while the term is the next elections in 6 months, it evaporates very quickly. So that's a reality also of difficulty of the prevention.
Okay. Well, thank you. Not necessarily a good perspective then to see the reduction, I mean. Okay, thank you, Jean-Marc. Any question? Any other one? If not, thank you again very much. I suggest we move to the second topic of this session, AMR, so antimicrobial resistance. And I would like to invite the first speaker in this session, who is Prof. Wibawa from Universitas Gadjah Mada in Jakarta in Indonesia to talk about AMR. So please, Prof. the floor is yours.
Thank you. Yeah, thank you, Prof. Brutus. May I share my screen? Can you see my slide now?
Yes.
Yeah, okay, thank you. Yeah, first of all, thank you very much for the organizing committee, Prof. Brutus, to invite me to join this excellent and very precious symposium. And let me also introduce myself. I belong to the Department of Microbiology in my university, and also I'm the chairman of the One Health Task Force in the university also. Okay, so today I will talk about the antimicrobial stewardship, and I think that it is not only in the hospital we need to emphasize this antimicrobial stewardship, and of course, it is going to be in the One Health approach perspective. Yeah. Again, let me start with very beginning of the problem about the antimicrobial resistance as a global trend. So, some people actually already mentioned that this is going to be the silent pandemic because AMR infected person, AMR microbes can be involve all people, all age, all region, and also educational status, social status, etc. Right? And then the AMR actually it is can be occur naturally because of the possibility of the mutation, possibility of the evolution, and also recombination among the microbes that we have in our world. And then because of the use of the misuse of these antibiotics or antimicrobes in the human, animal, and also in agriculture sectors, then it can really push the situation. So it can speed up the process of the AMR itself. And of course, you want to understand that the catastrophic effect in human beings will be people sick, ill people will be difficult to be cured, prolonged hospitalization, increased healthcare costs, and it is very serious. And then it is also going to be increased the mortality rate among the people that is infected by the microbes that is already not susceptible to the antibiotic or antiviral or antifungal and other antiparasite. And then one prediction actually that the catastrophic effect of the AMR in the 2050 will be around 10,000 death, 10 million death, sorry, 10 million deaths per year. And then this is the data that is documented in 2022, and then it is around 1.3 million already. And then, of course, this is going to be comparable with the cancer death, the death because of the cancer. Yeah. Then, what about 2022 until 2050? There is a publication to 2024 by the antibiotics and collaborators. You can see here that we are here now, and then the attributable and associated death because of the AMR will be increasing. And then still, the prediction that is going to be around 10 million death per year will be not really similar, but it is maybe it is projected around 8 million per year, for example. So the 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 threat is there. Yeah. And if we come back again to the theoretical framework of the how AMR can be developed, is that we are have many microbes in our in our in our body and also in the animal and also in the environment. And because of the use of the antimicrobial product, it can be uh, make like selection pressure. Selection pressure means that the antimicrobe antibiotic will kill several microbes, several bacteria that is susceptible, but some of the bacteria that is not susceptible will be survived. And then apparently the non-susceptible microbe will be the one that is dominantly circulated around us. So probability that our people getting sick, getting ill because of infection of the non-susceptible will be much more higher comparing with the situation if we are not uh, we are not have the selection pressure before. And then apparently we also have to uh, mem- uh, take consideration about the possibility of the transmission of the antimicrobial resistant gene among the microbes. Yeah. So this gene that is responsible for the trait of the phenotypic where the antimicrobial exposure will not kill them, will be transmitted from one strain to another strain, on one genus to another genus, and one even from the pathogenic to the non-pathogenic, or vice versa, from the non-pathogenic to the pathogenic to the animal and to human being. So we can now identify the key causes of the AMR is that the keyword is the selection pressure. So overprescription of the antimicrobial, overprescription of the antimicrobial, or over administration, or even or open dispensing. And then after that, certain courses of incomplete compliance with antimicrobial treatment. As we know in our situation, sometimes because of the shortness of the resource, so the antibiotic or antimicrobial is costly. So maybe we will keep the shortened period, or even it is related with the compliance of the people. People doesn't like to take my pills for maybe 10 days or even 7 days, for example, or even 14, or even in the fungal, for example, for week, 8 week, for example. So they are quit in between of the during the course of the treatment, for example. And then antimicrobial overuse in livestock and fish farming. Uh, I'm not the I'm not the expert in the animal or in the veterinary medicine, but I just read that it is true that the overuse of the antibiotic is present in the livestock and also in the fish farming or aquaculture. And then in our case, poor infection control in healthcare setting. Actually, it is not only in healthcare setting, maybe, but it also related with the same situation in the farming. For example, the infection control or uh, containment in the farming sometimes is problematic. Even in our case, for example, farming sometimes is not a big farming with a good containment, but maybe the backyard chicken or even the pet that actually surrounding us every day. And then another situation is because we have a poor hygiene and sanitation. And the global problem now is the limited discovery of new antimicrobials. The pipeline of antibiotic investment invention is antibiotic invention, antiviral, and also antifungal even is very dry now because maybe maybe it is very difficult, or it is because of the nobody want invest in that sector. So we're talking about the antimicrobial resistant organism or multi-drug resistant organism, for example. So actually, learning from this picture or figure, actually we understand that we are sharing actually the antimicrobial resistant microbes, the multi-drug resistant organism, for example, will be spread, will be able to spread from human to the animal or animal to human, and then they can spread from between the human itself among us, and then coming to the our pet, and then after that, maybe we can see the spreading between the animal from the wildlife to the livestock, for example. And eventually the environment can be a reservoir or buffer that is going to be facilitate the spread. Uh, one uh, One message is that we are sharing the microbes, and then because the microbe is now becoming resistant, so we are sharing the resistant microbes between animal, people, and also environment. And then if I want to pinpoint about the three component of the interconnected in AMR in one health perspective, of course, is that we have a problem with the antimicrobial drug residue that is circulating among three sectors: human, animal, and also environment. And we have the antimicrobial resistant microbes, just I mentioned from the previous slide. And the last thing is that we are sharing also the possibility of the possession of the antimicrobial resistant genes among our microbes. We call it AMR microbes because actually we are living with that. And actually, it is already uh, already well known about the we call it as holobion. Holobion is sharing about that one. Yeah. Then I want to show this diagram, this picture. Just want to remind you that that possibility of the transmission of these three indicators: the antibiotic residue, the antibiotic resistant bacteria, and the uh, anti uh, uh, anti sorry, antibiotic resistant or ARG. So this meiosis, yeah, antibiotic residue, antibiotic resistant bacteria, and antibiotic resistant gene will be the actors that is going to be transmitted from, for example, in one case, it is hospital, but actually it can be changed to become a farm or it's become a poultry, for example. Because in the hospital, farm, and poultry, we recognize that these three places are they are places where the antibiotic will be used a lot because of people are sick, people have illness, people have infectious disease, or even the animal have a disease also. And also, maybe we need also to prevent the fish from becoming infected by the bacteria and also virus. And then from this hospital or other place I mentioned before, we have a wastewater system actually. And then there are two possibility, but I hope that every hospital, every farming, and also every uh, industries that is using the antibiotic will have the water treatment plants. And then actually using or without this wastewater treatment plant, actually this three indicators, the antibiotic residue, antibiotic resistant microbes, and also antibiotic resistant gene will be still going to go to the effluent of the water treatment plants because as we know that the quality control of this water waste treatment is not included whether it is already filtering the three indicators like antibiotic residue, antibiotic resistant microbe, and also antibiotic resistant gene. And then it's going to be flushed to the environment. And then after that, going to the surface water. And this water will be go to the agriculture use, going to be livestock use, and also even going to our household to become daily uh, uh, water that we drinking or we cooking or even we are using the water to clean up our dish, for example. So actually, by using this situation, actually the model of this transmission will be there, and we are aware about that. Okay, and then what about in Southeast Asia? So in this is Asia, including Indonesia, of course. It is play pivotal role in the global fight against the AMR because what? Because we have a high population density. High population density will be resulting into the human encroachment. Human encroachment will resulting to the land use for housing and also even land use for the agricultural intensification, of course. And then after that, the one's health concept about the transmission about the IMR will be there because we are close related to each other. And then diverse ecosystem, for example, we have very wide biodiversity, we have climate change, and we have also some culture that is possibly different with other places. And then we have also unique healthcare challenges because some of our healthcare is not really good. But the other, of course, is very nice because it is related with rapid economic development that is not even in the Southeast Asia. So in the developed countries like Singapore and another country, maybe it is good enough to cover all the AMR problem. But the other country that might struggling to do that because the economically not as good as the developed countries. And then the last thing is that we are always anecdotally we are living in the epicenter of emerging infectious disease and also of course AMR because of this situation. So the driver AMR in our regional in our region is because of the three problem. The first is the overuse or misuse of the antibiotics itself, and then environmental contamination by the antimicrobial resistant microbes and also antimicrobial residue and also the antibiotic resistant gene. And then the other thing is that regulatory and enforcement gap. So I believe that all the countries have the regulation, have the guideline, and the decree to control the AMR already. Even all have a national plan for the antimicrobial resistant uh, to tackle down the problem, right? But sometimes the implementation is another problem, right? Because sometimes the regulation is not really implemented 100% like we expected, but we need to enforce that one. And then the misuse is not only in the human health, but also in the animal, in the and wild animal, and also in livestock production, and also in the agriculture and aquaculture. Yeah. So let's see this figure, this graph. We want to talk about the livestock animal use of the antibiotic, how the antibiotic use in the livestock, for example. Yeah, it is of course it's different, very different amount of antibiotic we use. If we talking about the chicken, for example, here's only 35 milligram antibiotic per kilogram of meat. Why it is small? Because chicken is small, and sometimes and somehow we are harvesting this chicken poultry only for maybe 42 days. So it's very short. So the use of antibiotic might be very small. But the problem is that if we have this 35 milligrams antibiotic per kilogram of meat, then for example, one chicken is around one and then 1.5, or even sometimes we can until 2 kilograms. And we have thousands of poultry, and then each poultry have maybe 10,000 until million of chicken, then of course the consumption of antibiotic will be very high. And then what about the sheep and cattle and pigs? And then they have also have different amount of antibiotic that will consume because different uh, different strategy, different technical SOP to do breeding of these three kind of livestock. For example, why it is not why the cattle is not as big as pig is because usually pig are bred in a very close, and then the human involvement is very high. So of course the possibility to have the antibiotic intervention will be greater than the cattle, for example. And then however, though the consumption of the antibiotic in every livestock type of livestock is different, but there is one study that trying to use the population corrected unit, and then you can see here that uh, unfortunately the Asia region is the one that is consume antibiotic uh, uh, bigger, the biggest one in Asia. And then less consumption of antibiotic in the livestock is in the European countries and also the African countries. I don't have any idea why these are different, but this is the fact. This is the statistical number, and sure, because we are in Asia, so we have a big problem. And then anecdotal data showing that always saying that the use of antibiotics is actually around 60 to 70% is in the animal sectors, but not in the human sectors. Okay, then I want to show you about the problem of the use of antibiotic in the human, but not in the hospital, but it is in the community. So one of the our study, I was one of the researcher that is involved in this study. We call this PINTAR study. So we do the study in Indonesia, and then we using the standardized patient to visit the pharmacies and also uh, drugstore, and then we have this number around 69% of the antibiotic was dispensed without prescription. So basically, we train the standardized patient, and then this standardized patient will come to the pharmacy, and then they are acting as people that is have illness for the in and for the gastrointestinal infection, respiratory tract infection, and also urinary tract infection. And then we have this number. And then, of course, we can conclude that inappropriate dispensing of antibiotic by private drug retail that is spread in the whole countries in Indonesia is widespread. So thank you very much for the team of the Pintar team that is rise this one, and then this is going to be one of the reference for us that actually there is a problem of the antibiotic dispensing in our community. And then further study, trying to find out why the number is so high. And then we find this model. We do the qualitative study for this. Yeah? And then this was again, it is Pintar study here, one of the paper that is published already. So the problem is come for when the patient doesn't have enough money to pay for the for the fee for the healthcare, or they don't have the health insurance. And then another possibility is that the healthcare is so far away, and they are getting ill. So because of that, they directly go to the pharmacy or drugstore. And then after that, because patient have already believed that antibiotics can be used to treat everything, like if muscle is headache also, they think we need antibiotics, so they're starting to ask the antibiotic to the vendors. And then another possibility is that because the patient doesn't understand what about their ill, so they're asking some advice to the pharmacist, and then the pharmacist offering the vendor offering the antibiotic, because two possibility in the vendor side. The vendor is unaware if appropriate antibiotic dispensing practice and regulation. They don't know, or actually they are aware. But the problem is that uh, instead of refusing to give antibiotic without prescription, they know that they have to have a profit for their business. So because of that, they think, why don't I just give it? Otherwise, they're going to another pharmacist or another drug store. So it is going to be not profitable for them, for example. So that's just the model that we found in the community. And then further study, our group also have this study. We call it as a neon study. We trying to find out the possibility of antibiotic dispensing that is not in the pharmacy, that is of face-to-face interaction between the patient and the pharmacist, between the vendor. But there are also a lot of online antibiotic seller that is present in Indonesia. And then we using the place is in Java Island, and then maybe you already know that Java Island is around 75% population there. And then we find around almost 4,000, so 3,790 antibiotic online antibiotic seller. This is we survey, and we survey only three marketplace actually, and then we can find this much of antibiotic seller. And then most of them are actually pharmacies. So actually the license doing pharmacy, the license to prescribe antibiotic, to the license, all the regulation, all the uh, all the regulation is there. So meaning that it is legal actually. And then the government also have the problem to sorry, have the regulation to regulate the online antibiotic seller actually. But there's a bit gap that we find is that because there is no direct interaction between the patient and the pharmacist, so there is a lack of information, essential information that is going to be resulting to the uh, misuse of these antibiotic. For example, they only 74% in this online system, they describe about the contraindication. Only 76% they describe how to use the antibiotic test, and also almost half they don't give the information about the side effect. So this is not a good practice for the pharmacy because of situation. The situation is that there's no direct interaction. So because of that, the information is not convey 100% to the patient, right? So based on that study, we going to talk about how we can do the antimicrobial stewardship. Especially, let's start with the animal and agriculture. In OIA, we know that in 2015 they released the resolution number 26, that is uh, entitled as combating antimicrobial resistance and promoting the prudent use of antibiotic action in animals. And then also there is many guideline that is related with the stewardship of antimicrobial in the animal side, and also in the veterinary medicine. That is very complete. That is very comprehensive. The elements there, everything is there, but there are still potential gaps. The potential gap is that maybe there is a lack of enforcement, like in the community and human over the counter cells, because still there is a antibiotic that might be present in not in a pill, but maybe as a supplement for the food, for example. Lack of national guideline, data limitation, and surveillance deficit, because there is no, maybe there is no system for surveillance about the AMR in the animal side. Public awareness, there's maybe the gap of the public awareness, and then limited infrastructure like laboratory to do surveillance, uh, the liability to culture and doing the antimicrobial susceptibility test, for example, and also the implementation of the One Health approach. So this seven item maybe the potential gap that might be uh, 100% guarantee that the guideline and then this element, the theoretical thing, will be found in the field. And then what about in hospital? There is also, yeah, there are many national guidelines. There are many guidelines from the professional organization and also from institution. And then there is also guideline where to how to intervention in the hospital, yeah, in the hospital especially, because usually the antimicrobial stewardship will be implemented very strict in the hospital. There is a six item that is that should be implemented during prescription, and then after that maybe another four items should be implemented after prescription. So I just want to say that actually the guideline, the regulation, the system maybe has already developed, but according to the problem, maybe the gap might be not in the hospital. Yeah, though I'm not saying that 100% of the antibiotic stewardship has been implemented very nice in the hospital. There are many hospital that is good, but there are another hospital that is not even understand how to perform the antibiotic stewardship in the hospital setting. And what about in the community? I'm not really understand. I'm not sorry, not I'm not really sure, but this problem, I mean, I cannot find the guideline for the antibiotic stewardship in the community up to now. But at least we need to do this. We need to do this to implement the antibiotic or antimicrobial stewardship in the community, because I just mentioned before the problematic the present of problematic problem in the community about the antibiotic dispensing. So first is the strengthen regulation and enforcement. Regulation is there, I'm sure, but the enforcement is to follow, because we need to monitor, we need to do surveillance, and this is going to be related with the human resource and also uh, uh, budgeting, of course. The second is that pharmacist and drug seller training. And actually, we do the interventional research in our in the printer study, and then we do the intervention to the pharmacist, and then it is good because the prescribing, the dispensing of the antibiotic without prescription becoming lesser in the intervention group comparing with the uh, non-intervention group. So pharmacist and drug seller training is very essential. And then the third is public awareness campaign. As I mentioned before, uh, people sometimes believe that antibiotic can cure everything, not only bacterial infection, but also the other disease like a headache or muscle ache or other possible illness that you can see. And then the next is the improve access to the qualified healthcare. One of the factor where people go to the pharmacy directly without consulting to the doctor is because of the access of the healthcare. Because maybe healthcare is sometimes going to the healthcare need time because there are many people, and then the queue is very long. Then we have to spend a lot of time. For example, it is one high station that we might uh, uh, that might be found in the patient. So they just go to the pharmacist to directly and then get advice to get antibiotic, for example. Surveillance and monitoring, and the last thing is that engaging the community leaders and local culture to make sure that antibiotic or antimicrobial is only used when it is necessary, because if we use this antimicrobial drug very frequent, then it is going to be boosting the it is going to accelerate the antimicrobial resistance or MDRO or other bacteria that is not going to be able to be killed by the antimicrobial. So I think that is the last last slide. Thank you very much. And then please, I keep the time and also the Zoom to Prof. Roger Frutos. Thank you very much.
Thank you very much, Prof. Tri, for this great presentation. I will have one question later for you.
Okay, thanks.
Right now, I suggest we move to the last presentation in this session, which will be given by Professor Walid Abuhammour from the Mohammed bin Rashid University in Dubai, in the United Arab Emirates. So second talk on antimicrobial resistance. So please, Professor Abuhammour, the floor is all yours.
Thank you so much, Professor Roger. It's really a great privilege to be with you today among all those eminent speakers and different varieties of topics which are appealing to the public health worldwide. And my colleague, he just set the stage for me when he talked about antimicrobial resistance. My focus, it is the hospital and patient-oriented antimicrobial stewardship program, and allow me to share my slides. Can you see my slide?
Yes, absolutely.
Okay. Actually, this is a new lecture for me because this is a new perspective from my experience with pediatric patients admitted to Al Jalila Children's Hospital, which is a tertiary hospital. I am a professor of pediatrics, consultant pediatric infectious disease, the head of the department, the chair of antimicrobial stewardship program, as well as the infection control at Al Jalila Children's Hospital. And my title is Beyond Antibiotics, a host-directed approach to antimicrobial stewardship. It is very interesting that I ask many people when I used to give this talk or this lecture, what's the meaning of stewardship? Believe it or not, majority of people, they don't know. So one of my goals is to talk about what is stewardship in general and what is antimicrobial stewardship program, what are the goals in general, as well as antimicrobial stewardship program post-COVID-19 pandemic. To me, I think COVID-19 pandemic divided the timeline or the eras in medicine to pre-COVID-19 pandemic as well as post-COVID-19 pandemic. Things changed. What's the future strategies in antimicrobial stewardship program, as well as I will present interesting two cases to support my talk. Always, to be honest with you, I put this slide as the first slide when I present, and I ask the audience, what do you think? And everyone has different perception, which I agree. You know, this is lovely scene, greenery. You wish if you spend a day there. But my aim and the goal is different, actually, to emphasize that knowledge is cumulative and a continued journey. Why I'm saying this, and I think all of you agree with me, COVID-19 pandemic exposed all the healthcare systems worldwide and exposed the preparedness, exposed the agility, exposed how much we don't know, at least about infectious disease and pandemic. And you agree with me. During COVID-19 pandemic, I published a paper in Lancet Open about applying agility to the most of the countries, particularly European, United States, the others, about agility, application of agility on those countries during the COVID-19 pandemic and whether they passed or failed. and majority failed. And the top is United States, believe it or not. Exceptionally, Korea and Japan, they did relatively well worldwide. I didn't include the Middle East in this study. But it was an eye-opener to really look about what we know and what we are missing. And I think we are still here. Okay, stewardship in general is taking the care, planning and management of resources is in an ethic and responsible way, and regardless of the resources. It could be antibiotics, it could be people, it could be agriculture, it could be animal, it could be anything. This is stewardship. So, two magic words about it is an ethical and responsible way. This is the stewardship. For different religions, and you agree with me, proclaims everything belongs to God. We manage the property of our Lord. So whether we like it or we don't like it, 90% of the people on this earth providing stewardship toward this universe. Of course, not 100%. And maybe I'm exaggerating when I say 90%. But all religions, big advocate for you have to be good steward for our universe. And this is the stewardship. These are examples of stewards. The flight attendants, the best example, and the other name people, they call them steward. Another stewards. So Al Jalila, this is my hospital here, Al Jalila Children's Hospital, and everyone involved in the antimicrobial stewardship program. It is not only physicians, nurses, infection control, pharmacists, microbiologists, administration. So everyone should be involved in this antimicrobial stewardship program. What's antimicrobial stewardship? It is a process designed to optimize the appropriate use of antimicrobials. And it is very important that the healthcare workers, they have to comprehend and perceive this clearly, that antimicrobial stewardship program, not to police them, not to restrict and to make their life harder. No, it is appropriate use, whether we have to escalate or de-escalate. The magic word is optimize appropriate use. And the goal is to improve antimicrobial use, prevent resistance, reduce cost, reduce adverse effects, decrease length of stay, and improve patient care. This is very nice slide, I like it. The first three, it is simply about quality. And the second three is simply about safety. So if I have to summarize antimicrobial stewardship program, simply it is to improve quality and safety through the appropriate use of the antibiotics. The wrong reasons or the wrong messages that we don't have to deliver to anyone, that antimicrobial stewardship program, the main goal is saving money. This is a big mistake. And also administration cannot control physician prescribing, but we think pharmacy can. This is also wrong. If you don't have the support of the administration, big support, your program will fail. So this is big two no's for delivering the message. Why does antimicrobial stewardship matter? my colleague, he just made the life easy for me about tons of or million of doses given. This is for United States 2004. 200, 300 million of antibiotics courses are prescribed annually. I presented this slide and I looked to 24 and I could not find much difference, even increase in the number of prescriptions. The same percentage, it is almost 40% of all patients admitted to the hospital will get antibiotics. Very costly. More important than this, 30%, around 30% were given antibiotics for wrong reasons and wrong doses. And this is total outpatient oral antibiotics prescription in 2024 in the state. Just the oral outpatient, 255.9 million total oral antibiotics prescriptions. This is huge, at a rate of 752 prescriptions per 1,000 persons. This is huge also. When they look at younger than 20 years and more than 20 years, I would say here number of antibiotics prescription millions. For the pediatrics, 55.7. It makes sense because the number of population of pediatrics way smaller than the adults. For adults, 200. But more important, if you adjust the rate per 1,000, so it's almost similar. 679 and 775, I would say similar, which tells me we are very liberal to prescribe antibiotics. And still we have not done much progress in this. The scary thing, and this is what I'm talking in my presentation always, the international, globally security threat is not World War III. No, it is not wars. It is antibiotic resistance worldwide. This is the major international security threat. And Dr. Alexander Fleming, in 1945, he could predict the antimicrobial resistance. He mentioned that just add simple drops of antibiotics to the bacteria and you will get the resistance right away. And also my dear Paul Ehrlich, 1845, 1915, he said, this is 1908, drug resistance follows the drug like a faithful shadow. And 19, we are in 26, hundreds of years, proven he was correct. He was ahead of the world with many, many years, hundreds of years. And since then, we have not done really good work. It was so alarming to the extent the IDSA and the President of the United States, all the healthcare societies, they were panicking about it. And they came up with bad bugs, no drugs. And this is true because we have multi-drug resistant organism. More important, the pipeline getting dry. And why to invest in antibiotics for the pharmaceutical companies? Because it is not rocket science. To have the molecule in the market, to sell in the market for any antibiotics, usually it costs $1 billion. And it takes almost 10 years. So anyone has active brain cells will not invest in this medicine because in no time it will be resistant and it will be in the trash. That's why they shifted to the what's called the medication that money-making drugs like Cialis or the other medications for chronic diseases like diabetes, hypertension, obesity, Monjaro, because after all, they are business people. And this is the scary part. And that's why the United States, and this is from the higher authority, the presidency of the United States, that the government will subsidize or will give grants for the pharmaceutical company to do research and to come up with a new medication. But still, the pipeline is really dry. The resistance is very bad. It increases mortality and morbidity. Two times the mortality will be higher with the same infection, the same host, but if it is resistant or sensitive. To the extent we don't have any treatable antibiotics available for our patients. I used to have newborns, never visited any hospital or clinics, coming with UTI, pyelonephritis, or sepsis with ESBL and E. coli, or with multi-drug resistant Klebsiella pneumonia, because we bring the bacteria that it is resistant to his home. And my colleague, he mentioned about the agriculture and the food and the preservatives. So it is a long way to go. Antibiotic resistant, I like this slide. It tells you this, what's the impact of COVID-19 worldwide. And this is the CDC that released the new data on antimicrobial resistance threats in the United States. Before and after the pandemic, 2019, and during the pandemic and after the pandemic. And they came up with very interesting data. 6 of the bacteria increased by 20% after the COVID-19. Increased during the COVID-19, but still, if you look at the last column, 2022 versus 2019 pre-COVID era. That's why I'm dividing it pre-COVID and post-COVID era. 6 bacteria increased by 20%. This is huge. For very bad species of Candida, we call it Candida auris, increased by 6-fold. And a little bit background about Candida auris. It is health-acquired infections. It carries high mortality and morbidity. So one of the nasty Candida to be in any hospital. Interesting, the MRSA stable. Decreased a little bit, then becoming stable. What about GCC here? This is the GCC area and the Arab countries. Pre-COVID and post-COVID, you can see ESBL almost doubled. Enterobacteriaceae group before and after. CRE also, or carbapenem resistant Acinetobacter, big, almost 50%, 18 to 35. MRSA, a little bit of increase. So this is really very scary. And too many reasons why resistance developed, because, you know, every patient with COVID-19, he had to take antibiotics, whether Cipro or piperacillin tazo or macrolides. Why antimicrobial stewardship must evolve? Traditional antimicrobial stewardship, and this is till now, focused on pathogen eradication and antibiotic restriction, which is good, but it should not be the main goal. So we are really all these years missing the point or the vital point. It is important, but it is not the most critical direction to follow. Post-COVID-19 era highlighted the importance of host immune dysregulation in infectious diseases. And I have been experiencing this during the COVID-19 when we had. I published many papers even before it affected the children. That I could predict that severe cytokines, severe COVID-19 in adults that requiring ICU and dying and hyperventilation, etc. It was cytokine storm, and I published this several months after COVID-19 pandemic. This is inferent from my publications. I have a special interest in Kawasaki disease, and I could see from the literature published about COVID-19 in adults that there was great similarities between COVID-19 in adults requiring ICU and children with Kawasaki disease, simply cytokine storm. And I propose the treatment. You have to control the dysregulation of the immune system with immunoglobulins, corticosteroids, and to give aspirin for patients who have high D-dimer. I wrote a letter to the editor-in-chief for New England Journal of Medicine. I remember this clearly. April 7, 2020. So maybe in the first month of the pandemic, 2 months of the pandemic. Letter to him addressing this is cytokine storm. Unfortunately, he rejected the letter. I don't blame him because this is brand new for the world. However, in May, I published one, similarities between Kawasaki disease and severe COVID-19 in adults requiring ICU admission. And I published another one in about adult severe COVID-19 in adult is Kawasaki disease in adults. So I shed the light on this concept, but unfortunately, it was not taken seriously by many people, and we still patients suffering from this, particularly children, and I will come to it. Antimicrobial resistance accelerated globally after the pandemic, and I showed you the slides. And now there is shift towards precision stewardship. No more one size fits all. It should be precise medicine, and this is the future of medicine in the infectious disease. COVID-19 it had bad impact on the infectious disease in general, in specific in general in medicine, and on the resistance particularly. For any disease, 3 domains: host, pathogen, treatment. And this is true for the infectious disease. We have the host, we have the pathogen, which is the bacteria, candida, whatever, and antimicrobials. This model we used to follow for 100 years before the COVID-19, and still 90% of the people worldwide following this model: host, pathogen, antimicrobials. The center, it used to be the pathogen. The center for these 3 domains is the pathogen. And the most vulnerable domain that physicians play with is antimicrobials. So whenever there is patient not responding to the antibiotics, they will change the antibiotics. They will escalate. They will add new antibiotics. They will add antifungal. Regardless if the culture is negative or it is pan-sensitive. The patient is not responding. This is the weakest domain. And I think we are physicians playing with antimicrobials not for the sake of the patient, just for our sake, to feel good that we did something. And this is totally wrong. The shift should be toward host, not the pathogen. Pathogen, it has a role, but most important is the host. And we need a lot of work digging in the host because not two patients are alike. Even two identical twin, they are not alike when you dig deep in the genetic study. And this is, I talked about it. From traditional model, we have to shift to the host-directed model, integrate biomarkers, genomics, immunoprofiling, and I will add also AI. And this will end in precision medicine. So the ultimate endpoint or primary endpoint in treating patients with infections or severe patients in general, and this should apply for every disease, is the precision medicine. Not two patients are alike, one size doesn't fit all. Therapeutic strategies targeting host immune pathways instead of pathogen alone. I'm not undermining the role of pathogen, but I think it plays not more than 25% in the pathogenesis and outcome of the patient. And simply, I can give you example. Neisseria meningococcinia. All of you that Neisseria meningitis is very, very, very sensitive, fragile. One dose of antibiotics, it can kill it, eradicate the blood, eradicate it from the CSF, it eradicated it from the body. But the patient dies. And the mortality rate is very high, up to 10%, regardless what you do. So still our focus on the pathogen. The pathogen sensitive. We give the right dose, the right antibiotics. Repeat culture is negative, CSF culture negative. So why the patient died? Simply because of the host. What was going on with the host? It is hyperinflammation. And I will come to it. It is cytokine storm. So we have to improve the immune balance and recovery. Otherwise, we'll lose the game. Okay, this is how it goes. You have the triggers, and this is from my experience with children. Most of them, I'm seeing this with viruses, by the way. Bacteria it can give. And the best example, COVID-19 and evolved a new disease called multi-system inflammatory syndrome in children. So it is not bacterial, it is virus. And they related to COVID. But I think now we should change that it is connected to COVID-19. No more it is connected to COVID-19. COVID-19 is one trigger. I have seen it with influenza, RSV, adeno, dengue, malaria, Neisseria, salmonella, just name it. So it triggers. And in certain people, it triggers hyperinflammation, severe hyperinflammatory response syndrome. You have a twin. I had a twin identical, and I have twin not identical. I have siblings. They had the flu. Everyone had the flu. But one of them got to the ICU with severe hyperinflammation, cytokine storm. And the other is doing well. Why? Because it is the host. The pathogen, it is the same strain, influenza B or influenza A. The hyperinflammation will lead to the cytokine storm. And if it is not controlled, the cytokine storm, the immune system will be exhausted and it will be shut down. And this is what we call it immune paralysis. And it will be too late. I have many, many cases went through this route. I have also cases that went to immune paralysis and I'm sorry, HLH, I will say here, human HLH, not immune paralysis. And certain patients, they got both, which is very severe situation, and it has very high mortality, morbidity outcome. So excessive cytokine storm release mimic bacterial sepsis. And again, you know, if you talk to the ICU, whether adults or pediatrics, and they have patients dying, and what's the cause of death? You can say septic shock, but the culture is negative. They have the term negative culture septic shock, negative culture septic shock. I don't agree on this term. I don't agree on this diagnosis. No more I can buy in this term. It is not negative culture septic shock. It is cytokine storm. It is hyperinflammatory response syndrome, cytokine storm, immune paralysis. That's why the patient died, because we treated the bug, or even there was no bacteria. It is viral infection. And we were chasing the wrong guy, and the patient died. So I think we should change our treatment or management and our perception about infectious disease in sick patients. And this leads to unnecessary escalation of antibiotics, and to recognize it is very critical. And there are certain things to help us early enough to identify it. This is what I said. We should have rapid molecular diagnostics, PCR, point of care testing. The turnaround time short. I have known critical care areas, they can do the cytokine in point of care in the ICU. This is the way to go. So we should have rapid molecular diagnostics. The turnaround time should be quick, and this is very critical for the outcome. Host gene expression signature is still in the infancy stage. Luckily enough, we have very good state-of-the-art genomics lab, and I have been utilizing this for my patients. At one point, we have research projects. It's called Falcon project, in a very critical ill patient admitted to the ICU, and in 36 hours can give the answer. But this is on research-based project. I think it should be the norm, rather than just for the sake of research, because it helps a lot. Whether the gene, you can identify the patient has HLH, has a variant predisposing him to the cytokine storm, or HLH, or autoimmune encephalitis. I have bizarre museum of pathologies from cytokine storm. I would add also, we are living in the era of artificial intelligence, and still it is in the embryonic stage. The future, if I have to summarize, the future is for molecular diagnostic, it is for the genomics, it is for the AI, and the center should be the host. And the goal is precise treatment or precision medicine. Of course, when we identified it, we can give immunomodulators, biologics, cytokine blockades. Even we had patients, we had to do a plasmapheresis or microfilter pheresis also, plasmapheresis for our patient to flush out the cytokines. This is given nutritional and metabolic support. This is very important, particularly given the antibiotics will create imbalance in the microbiome, and dysbiosis, and everyone familiar with the impact of dysbiosis. Okay, I talked about it. Predictive models of sepsis and bacterial infection. I think this is very important to work on artificial intelligence. AI-assisted antimicrobial optimization and risk stratification based on host biomarkers. Early detection of deterioration. So there is huge work with the AI when it comes to sick patients with severe infection. In a pediatric perspective, children exhibit unique immune responses. This is very important. This is different from adults. Maybe my colleagues here in this conference, they are majority of adults, maybe pediatricians, and they can agree with me. Pediatrics, children, not small adults, totally different. And this is wrong perception. They are not total small adults, different creature, different immune system, different pathology, different defense, just name it. And they are prone to viral illnesses more than bacterial infections in adults. And this led to overuse of the antibiotics. And just to bring to your attention, viral infections post-COVID-19 pandemic becoming as aggressive as COVID-19 virus in dysregulation the immune system. And we need specific markers for the threshold. Precision stewardship, critical in the NICU and PIDS ICU. So COVID-19 lessons, high rates of antibiotic prescribing despite low bacterial infection. Immune dysregulation influenced the clinical decisions. Importance of distinguishing inflammation from bacterial infection is very important. Integrate host biomarkers with the clinical assessment. Use rapid diagnostic before escalation. Daily antibiotic assessment. Early de-escalation is very important. And we have steps to take whenever we encounter patients who are admitted with severe infection. We have to assess severity and host response. Again, the magic word host. And then evaluate biomarkers and immune phenotype, which we usually, most of the time, we don't do. And if we do it as routine and we don't pay attention to it. Use rapid diagnostic, target therapy, and reassess daily, and also de-escalate. Benefits of host-directed antimicrobial stewardship program: reduced unnecessary antibiotic exposure, lower resistance, improved patient's outcome, reduced healthcare cost, better preservation of microbiome in our health. Cost of advanced diagnosis, these are the challenges, but I think it pays off because we are dealing with saving lives. We are not talking about patients with runny nose, common cold, or diarrhea, or gastroenteritis, or children coming for vaccination. No, we are talking about critically ill, sick child that is in the critical care, requiring oxygen, high ventilation, and on the verge of death. We have need for clinical education, limited access, this is important, need for standardized pediatric threshold. The future directions, we have to integration of genomics and AI in routine care, personalized immune profiling, point of care, and collaboration globally. I'm running out of time.
Yes, we need to wrap up because we have
okay, just
we
one case.
Have a plenary session after that.
One case presentation.
Yeah, thank you.
this is, this is the 3-year-old in 2 minutes. 3-year-old local Emirati child. He is part of a twin sister. He is a boy and his sister twin, girl. Both of them developed influenza B. The girl was doing very well and remained very well. The child admitted to the critical care area, very sick, vital sign. He was in shock, just to make it brief. And all the labs consistent with what's called severe cytokine storm, and hopefully I will show. And you can see here, he was on ceftriaxone, vancomycin, and Tamiflu, and escalated to meropenem, which is really very, very, very. And this is the cytokine storm here. The patient has all the phenotypic for cytokine storm, you can name it. And you say, this is the first chest X-ray. The second chest X-ray, even worse, he developed severe cytokine storm. We give to working on dysregulated immune system, we give high-dose IVIG. We gave initially steroids. We were skeptical, but we gave him high dose, and we gave biological. The chest X-ray was getting worse. You can see necrotizing pneumonitis and getting both lungs involved. And he developed white-out lungs. He developed secondary bacterial infection, strep pneumo, developed pneumothorax. We could not ventilate him on high frequency. He had to be under the ECMO, and you can see the ECMO tube. Filled the ECMO twice, transferred to for lung and heart transplantation. And this is the patient. Another case with RSV, but I can stop right here. Thank you so much. And this is, by the way, one of the publications we published at Al Jalila. I was the lead on this. Genetic and characteristic of patients in the Middle East with multi-system inflammatory syndrome in children. Integrating that big study on the genetic, which is very good study and eye-opener for the future. Thank you so much.
Thank you very much, Professor Abuhammour. We must move a little bit because we have a plenary session starting in 12 minutes. And I invite you to attend this plenary session with the general link, not that one, but the general link for public. But we still have time for one short question, and I would like to forward the question from one attendee. It's Miss Yulita Saferahurai, who is a student from the Dynamic Master Program. Initially, the question was to Professor Tree, but I guess the question is valid for both speakers, actually. So let me read the question, which is in the chat. Is thank you for the insightful presentation, Professor. I'm Yulita from Dynamic Student, and I found this topic very relevant to current AMR challenges. I would like to ask, based on your experience, what are the main challenges in addressing antimicrobial resistance at the primary healthcare level, and what practical steps can be taken to improve antibiotic use in clinical practice? Thank you. So we have a very short time, maybe 5 minutes to answer. So both of you.
Thank you so much for the nice comment, and this is very interesting question. The challenges I'm facing really after COVID-19 is that in the critical care areas, still the perception about the evolving precision of the medicine and immune dysregulation and hyperinflammatory response syndrome, cytokine storm, immune paralysis, this is the main obstacle and the challenge for me in the hospital. For the routine antimicrobial stewardship program, I think we have been in this business for a while, and once you build a culture among the healthcare workers about antimicrobial stewardship program, the challenges will be much easier. So I will put emphasis on education, and education, and don't give up. Still, every day I'm going to the critical care, I repeat myself. Some of them becoming receptive, 100%, some 75%, because Professor Roger, when you are used to certain work for 10 years, 15 years in your practice, change is difficult. And always people, and this is a relatively new concept in the pediatric infectious disease, the host-centered and the immune dysregulation and hyperinflammation. That's why, when I'm involved with this, I always, when it doesn't make sense to me, I ask for the phenotypic cytokine storm. I made the recommendation. Surprising, the next day, they didn't follow my recommendation. Always they follow, sometimes 2 days after, when they could see the worsening. But now we are getting more and more better in this concept. So, which I don't blame anyone, because this is a new concept, and changing the mindset of people is not easy. And you have to be persuasive. You have to be dedicated and passionate.
Okay, thank you, Professor Abuhammour. So I would like to ask Prof. Tree, what can you say to answer Yulita's question?
Okay. Yeah, thank you very much for the question. It is a very nice question. And you are asking about the primary health care. Primary health care means that it is not the hospital, right? So it's like a very small clinic. So what I want to highlight is to make sure that the physician that is working in the healthcare, in the primary healthcare, have the knowledge and capability to do the diagnostic, exact diagnostic, the correct diagnostic, that if you give antibiotic means that you believe that it is really bacterial, not viral, not fungal. And then how to replace their capability to diagnosis? Maybe because the infrastructure for the laboratory, for example, they are not really have enough resource in the primary healthcare, especially in the developing country like us. So what we post this just to make sure that everybody reading the clinical practice guidelines. Clinical practice guideline. If they don't have, then they have to have that. And then after that, everybody have to follow the guideline. Otherwise, there will be a improvisation from every physician to prescribe the antimicrobial, like antibiotic. That's the two things that I think it is very well, important and very basic thing for the primary healthcare. Thank you.
Thank you very much, Prof. Tree. Thank you very much. I also would like to thank all the speakers who presented their work and perspective in this session, or these two sessions, actually associated within one a global session. I'm sorry, we need to close the session now because we need to move to the plenary session for the keynote address. They are already online. So if you want to attend this plenary session, don't use this link. Use the general public link to connect to the plenary session. And so again, I thank you all very much for everything, and I will contact you with respect to the publication on both separate topics, pollution and AMR. So again, thank you very much, all of you, for your participation. Thanks a lot, and I'll see you very soon on the on the keynote address and the session this afternoon. Well, this afternoon for me, if you want to attend, this evening for you. Thank you very much again to all of you. Thank you. Goodbye.
Thank you very much.
I'm closing and going to the plenary session.
Can you hear me, Professor Roger?
Thank you. Sorry?
Professor Roger, can you hear me? Can you hear me?
Yes, I can.
Yeah, you know, I have a clinic, you know, patients waiting in the clinic. Do I have to be in this? It is regarding my lecture, questions regarding my lecture, or I can excuse myself?
I don't understand exactly what you mean. Sorry, I didn't hear well.
Yeah, because I have a clinic today and I have patients in the clinic.
Oh, okay. Well, it's no problem.
If I have to stay for questions for my lecture, I would, but I cannot.
Okay, if there is any question, I will forward it. You can use by email, and I will forward the questions by email.
Okay.
Okay.
Thank you so much again.
Thank you. Thank you so much to all of you again, and hopefully see you soon. Thank you very much. Goodbye to all. Bye.
Thank you. Bye bye.